Hi, everyone. Welcome. Just making sure everybody's come in from the waiting room. Looks like everybody has. Good to see all of you virtually, and welcome to the 16th Crisis Response Improvement Strategy Committee meeting. This is our August meeting, and I am Jamie Strauss-Clark, your facilitator. It's good to see everybody. Let's advance the slide, please. Just going to do a little bit of my typical housekeeping at the beginning of the meeting, and then we can dive right into the agenda. I have two slides here. One is for our CRIS committee members, and the second slide is for our community members and guests. So we'll go through the CRIS committee slide first. And I know you're all probably really familiar with this by now, but just a quick reminder to please keep your mics on mute unless you are speaking in the meeting. That will just minimize the background noise and distractions. Chloe, if you could just hit the advance button. I'll remind everyone where that mute button is. If it is available to you, particularly during the part of the meeting where we engage with each other in discussion, which is going to be after the break today, if you could please keep your video cameras on, if that's available to you, that really helps with our engaging with each other in facilitation. Advance the button, please. We use raise your hand function to indicate when we want to make a comment or ask a question. So you can click on that reactions button. It pops up a window. Advance it, please, Chloe. And you'll see the raise your hand button there. And then I can help you lower it when you're done speaking. Also, if you have trouble finding that button in the moment, just wave your hands at me and I will try to call on you in the order in which I see you. And then advance, please, Chloe. CRIS committee members, if you feel like today you'd rather communicate in written form rather than verbally, please go ahead and send it to me, Jamie Strauss-Clark, in the chat. And as I'm facilitating the discussion, I will pause between questions and check and see what's happening in the chat. If you would like me to share your comment or question anonymously, please let me know at the beginning of your message and I will make sure to do that. Otherwise, I will attribute the comment or question to you. Advance the button, please. Finally, if you'd like to have it on a view where you can see your fellow CRIS committee members during the discussion, you can click on that speaker view button up in the right corner and change it to gallery view. All right, let's move to the next slide. So this is a very similar slide, but it's for our members of the public. And again, I want to extend a huge welcome to all of you and a thank you for taking time out of your schedules every month to be part of these meetings. Similar instructions here. If you could please keep your mics on mute for the duration of the meeting. If you sign up to make public comment today, that will be at the end of the meeting, and I'll invite you when it's your turn to unmute at that point. But otherwise, if you could please keep your mics on mute, that would be great. Advance the button, please. I'm going to ask members of the public if you could keep your video cameras off for the meeting today. Again, it's you've heard me say this before. We have today we have 55 people here, and usually we get a few more as we get going. And so it really helps me if you have your video cameras off to know who in the CRIS is participating and facilitate with them. Please advance, Chloe. All right, and the same note to you, you can click up on that speaker view button and change it to gallery view to see more of the CRIS committee members in the discussion. Just a couple more notes. We do not have ASL support today. We've had a little bit of trouble getting people who are available these last couple months. However, we are able to use the closed captioning function. So if you need that support, actually, I'm going to pause for a moment and ask Brittany to instruct people on how to access that if they need it. Brittany, do you just click on the show captions button at the bottom of the screen?
Yes, I've activated them, and so
okay.
They are running if you need them.
Okay, so, and if you could also write those instructions in the chat in case anyone's having trouble hearing me, that would be great. So again, if you need some support because of a hearing impairment today, please feel free to click on that captions button at the bottom of your screen. It's an imperfect tool, but it'll hopefully help you follow the meeting today. Let's see if there's any other housekeeping. Oh, and finally, just a reminder, if you are finding that your internet is unstable, you can also choose dial in for audio or you can also alternatively, CRIS committee members, turn your video cameras off. That definitely helps with the unstable internet. Finally, CRIS Committee members, when you're speaking today, if you could remember to just state your name and your role or representation on the committee, that'll help remind our community members who you are and how you're involved in this. All right, I think that's it for the housekeeping. So I would like to move directly into our welcome today. If Chloe, if you could take the slides down, please. I'm going to invite Adam Wasserman, one of our CRIS Committee members, to offer welcome remarks today.
Yeah, good afternoon, everybody. Adam Wasserman, I'm the state's 911 coordinator. And I want to welcome everybody to today's CRIS meeting. I was honored when they asked me to provide opening remarks for today's meeting, but also a little perplexed why Jamie would ask me to do it or what I would actually have to say. So I figured I was just going to speak, why am I here at all? So over the past several years, I've been involved with first 1477, then 988, and then the CRIS. And I've been asked on numerous occasions, why is the 911 coordinator spending so much time dealing with 988? And my answer, as Representative Orwell and I have mentioned several times, is that 911 and 988 are now forever linked. And like it or not, we're partners in the greater crisis response system. And when one of us fails, then we all fail. Understand, there is only one crisis response system in Washington. And 911, 988, 211, and the regional crisis lines are all access points into that system, as are the policeman out on patrol who comes across someone in crisis, or the community group that is engaging individuals at a homeless camp. These are all different ways that individuals gain access to the crisis response system. And no matter how they access or get into the system, we should be very happy and thankful that they got there. And we should be developing the type of system that gets the help and assistance that they need. That is something that I think we all need to keep front and center. We are all here with hopefully the same vision and goal of increasing access to and improving Washington State's crisis response system. And as we go through this long and arduous process, I get a little concerned that we're getting mired down in some of the bureaucracy and have lost focus on the vision and the reason we all initially wanted to participate in this process of improving our crisis response system. Unfortunately, it's easy to get caught up in the internal battles over funding and who is stepping into whose lane to a point where we lose track of the ultimate goal. And if we don't have a common vision and common goal, or let ourselves get sucked into the bureaucracy and tribalism, we'll continue to spin our wheels, and that ideal crisis response system that we all want will continue to be a dream, not a reality. If we can stay focused and make real progress toward the ideal crisis response system, who cares who gets the credit? As President Truman said, it's amazing what you can accomplish if you don't care who gets the credit. I was very impressed yesterday as we toured the receiving centers in Parkland and the one under construction up in Federal Way. Those teams have the right attitude, no wrong door. No matter who shows up or how someone shows up at their door, they accept them, no questions asked. Only if we come together as a team, and the same purpose and vision, and all pulling in the same direction, will we ever be able to accomplish something as big as what we're trying to do. And make no mistake, what we're trying to do is big. This goal is bigger than 988. It's bigger than 911 or 1477 or any of that. And it is going to take all of us to get this accomplished. That includes 988, 911, 211, the BHASOs, RCLs, DCRs, co-response teams, community groups, first responders, city councils, everyone working together. In 1961, President Kennedy was touring NASA. He saw a janitor with a broom, and he walked over to him and asked, "What are you doing?" The janitor responded, "Well, Mr. President, I'm helping to put a man on the moon." You see, that janitor knew the vision. He was sweeping floors, but he was part of something much bigger, and that is the type of mindset and commitment it will take from all levels and from all of us and stakeholders to accomplish the bold vision that we have. I'd like to put out a challenge for everyone, which includes myself. Ask, what are you doing? Is the first response building the premier crisis response system for Washington State? If not, maybe it's time to refocus a little bit. Remember, we're all on the same team here. And as Coach Herb Brooks of the 1980 hockey teams famously said, when you pull on that jersey, remember, the name on the front is a heck of a lot more important than the name on the back. Thank you all.
Thank you so much, Adam. And I hope you were just kidding when you said you didn't understand why I asked you to do this welcome, but that was fabulous. And I really appreciate the inspiring words to get us started today. Before we get started, I also just wanted to say something. I was just notified by one of our CRIS members that the Chief Executive Officer of Frontier Behavioral Health, Jeff Thomas, passed away last week. And I understand that many of our community members are grieving and mourning this loss. And so I wanted to acknowledge that. And just before we get started with our agenda, take a moment and offer, if any of our CRIS members would like to say some, Jan, I don't want to put you on the spot, but if you feel like you'd like to say something or put something in the chat, or if anyone else would, it sounds like Jeff was important to a lot of people. So just wanted to pause for a moment and acknowledge that. I also understand if people would rather just be silent here, that we all grieve in our own and important ways. And I want to say to everyone, I'm so sorry for your loss.
Thank you.
Okay, why don't we continue here? Chloe, if you could put the slides back up, please. I'm going to go ahead and review our agenda today. All right, if you could go back up one to the objectives. So we actually have a special treat today. We wanted to give we've been working very hard in these meetings, and we do have some work that we need to do today to finish our discussion about recommendations for someone to come, which is one of our objectives today, to set us up for our in-person September meeting, where we're going to really refine the recommendations that are going to go to the steering committee for consideration in the final report. But we also have a presentation from one of our very own, Michael Reading, as well as his colleague from King County, Kate Faber, who are going to talk to us about the King County Crisis Care Centers levy. And Kate was available until 2 p.m. today, so we're going to do that first, and then we'll save our discussion for later in the meeting. But we felt like this would be a good opportunity to learn from this team about what they're doing. So we're going to hear a presentation from them today on this topic and have some time for Q&A. As usual, we'll also hear updates from the state agencies. And then, like I said, we'll devote the remaining part of the meeting to finishing that discussion we were having back in July about recommendations for someone to come. So if you could advance the slide, please, Chloe. All right, so let me just give you the times we're aiming for. When we're finished here with reviewing this agenda and all the background and setup, we're going to move into our personal story. And then at 1:10, we'll dive into the presentation on the King County Crisis Care Centers levy. We'll take a break at 2 p.m. And then when we come back together at 2:10, we'll do the system updates and agency Q&A. And then at 2:30, dive into our discussion to finish those potential recommendations on addressing system gaps for mobile crisis response. At 3:15, we'll run through action items and next steps, and then move into our public comment period at 3:18 to adjourn at 3:30. Yep, so slide, please. All right, I'm going to turn it over now to Betsy, who's going to remind us about where we are in our process here and where we're going. So Betsy.
Hi, Jamie. Thank you. And good afternoon, everyone. Yes, I am going to take a brief minute just to orient us to our meeting today and the work that we're doing along the continuum of services discussion that we've been having this year. As you all remember, in July, we started to talk about a synthesis of recommendations relating to someone to come, including collaboration with first responders. We're continuing that synthesis conversation today, finishing up 2 of the focus areas on the synthesis document. And we will also have an update on our 988 Contact Center Hub rulemaking. There was a mention of this in the newsletter, and we will hear from Michelle Roberts around the plans for the rulemaking exercise. Next slide, please. In September, we will begin to discuss draft policy recommendations that will form the foundation of our January 24 committee progress report. That meeting will be in person. I think everyone is very excited to finally meet in person as a CRIS committee. So we'll be doing that in the CTAC area, and all are invited. And we will be having more conversation about the synthesis document. We will be synthesizing all of the foundational areas, a place to call, someone to come, and a place to go. And it will also include recommendations, input from our lived experience subcommittee, and recommendations from our tribal subcommittee. Okay, that's my update.
Excellent. Okay. I'm going to briefly review the public comment process before we move into our main agenda. I don't know if we have anyone signed up yet today. So if you would like to make a public comment, members of our community, please send a chat to Brittany Thompson and she will put you on the list. I'll call on you at the end of the meeting in the order in which you signed up. And as of now, because I don't believe we have anyone signed up, we can do 2-minute public comments. If I get a lot of signups before the end of the evening, I may elect to bring that down to 90 seconds, but I'll let you know as we get closer to the end of the meeting. Just a quick reminder about how those work. When it's your turn, I'll call your name and invite you to turn on your video camera and unmute your mic. I'll have a timer to track your comment timing, and I'll ask you if you can make sure to stay within that timing. If you do need an accommodation, like a longer amount of time for any reason, please do let me know ahead of time, and that will allow me to plan. And finally, just a reminder that these are public comments. The CRIS Committee will not be responding to them. However, if you do have a written version of your comment that you could also submit to us, that would really help. We'll make sure that gets in the compilation that our CRIS Committee members receive every month of public comments to date. And if you would prefer to make a comment via written form rather than oral, we'll go ahead and put that email box in the chat so that you can submit it there. That is a great way to submit a public comment if you prefer not to speak publicly. I also want to acknowledge that we have a few new CRIS Committee members. I think at least one of you is joining us today. We'll do some introductions when we get to the system updates portion of our agenda today. But we're very, very happy to have you here. All right. Oh, there we go. Brittany just put the email address in the chat for where you can submit a public comment. And with that, I think we can take down the slides, Chloe. And in a moment, I'm going to introduce Kristen Wells, who is a key member of our lived experience subcommittee. She's going to introduce our personal story today. I do want to let folks know that these stories, as you know, people are coming forward with great bravery and honesty to share their experiences. And today there are some slides accompanying the story that include images that may be very triggering for people in our community. So I want to give you that heads up and invite you to do what you need to do to take care of your own well-being, while also expressing great appreciation and admiration for our the person who's telling their story today, for sharing such a raw and vulnerable piece of their life with us. And now I'm going to turn it over to Kristen, who I think will also have that reminder for you as she introduces our guest today. Kristen.
Hello, as Jamie said, my name is Kristen Wells. I'm a member of the Lived Experience Subcommittee, and I'm also a licensed social worker that works in the mental health crisis system. Today, our speaker is going to be another member of the Lived Experience Subcommittee, Jocelyn McLaughlin, and she is going to be sharing some very difficult content with us today. A lot of the stories we hear in the CRIS are very difficult, but Jocelyn has felt that it is important for you to see the extent of what she was experiencing during the worst of her crisis. And so there will be some images of self-harm, which we know can be very triggering for folks in our community. If that's something that's going to be hard for you to see, please feel free to close the window during that section so you're not seeing the images, or take a moment to step away. Do whatever you need to do to care for yourself. But we want to make sure that Jocelyn is sharing her story in a way that is true to the experiences that she had, and she feels it's important for folks to have the opportunity to see what she has been through. Aside from this story, I'd like to let you know that Jocelyn, when she is doing well, has a lot of lovely hobbies to share with us. She's a painter. She loves reading, video games, watching Netflix, and spending time with her family and her pets. And she's someone who loves to travel. We're so lucky to have her as part of the Lived Experience Subcommittee, and I'm really looking forward to her having the opportunity to share her story with you all today. Jocelyn, whenever you're ready, you can go ahead, and I believe Chloe's going to have your slides up for you during the presentation today.
I'm ready. All right. Hey everyone, my name is Jocelyn McLaughlin. I am a student at Walla Walla Community College, and I am working towards my associate's degree in social and human services. I am on several committees, and I share my story of lived experience with middle schools and high schools across Washington State. I am always advocating for improving the mental health system, and I hope that all of you will be able to learn something valuable from this. Next slide. I was born on October 15th, 1996, and my parents and I moved to Walla Walla, Washington when I was 4 years old. Next slide. My oldest sister's name is Chrissy and her husband's name is Nick. Next slide. They have 3 kids together. My niece's name is Nicole. My oldest nephew's name is Dylan, and my youngest nephew's name is Camden. Next slide. My youngest sister's name is Kara. She is 21 and lives in Vancouver, Washington. I also have a brother named Michael, but I unfortunately don't have any pictures of him. Next slide. My mental health journey started when I was in elementary school. I started showing signs of ADHD, but I unfortunately did not get diagnosed early on, and I did not receive the correct treatment for it as a child due to the fact that ADHD tends to present differently in girls. I suffered a lot because of it, and I unfortunately failed every year from 2nd grade all the way through the end of high school. I was also suffering from PTSD, depression, severe suicidal ideation, and occasional auditory hallucinations by the time I was 8 years old. But I did not get diagnosed or receive the correct treatment for several years. I was luckily able to receive therapy by the time I was 11, and I did find it to be helpful, but the therapist I was seeing at the time unfortunately had to move away after I saw her for a few months. After she moved, I had no access to therapy for several years. Next slide. When I was in middle school, I started experiencing severe OCD and worsening ADHD, which further complicated my life and made it impossible for me to succeed in school. I was unable to function, and I lost the ability to enjoy my hobbies and live my life. I constantly considered suicide as a way out. I saw my pediatrician to get relief from the debilitating anxiety I was experiencing, but she was completely unaware that my anxiety was being exacerbated by the ADHD. She prescribed me Prozac, but it didn't help that much, and I continued to suffer for years after that. Next slide. By the time I was in high school, I experienced severe OCD, depression, ADHD, and suicidal ideation. During this time in my life, I had been on 2 antidepressants that were not effective, and my mental health deteriorated to such an alarming rate that I had to drop out of high school. My pediatrician finally told my parents after 3 years of overseeing my care that I was a complex case and that I needed to seek help from a psychiatrist. My parents started to search for a psychiatrist that I could see to get the help that I needed, but there was close to 0 specialists where I lived. They even searched for a specialist out of town, but none of the providers would see me because I was on state insurance. When my parents finally found a provider who would see me, they thought he was a psychiatrist, but he was actually a physician assistant. When I saw him for the first time, he thought that my ADHD symptoms were actually bipolar disorder symptoms. And because of that, I was misdiagnosed, and he put me on a cocktail of antipsychotics, antidepressants, and mood stabilizers. The medications gave me severe side effects, and he ignored every concern me and my parents had about the side effects I was experiencing. He also ignored the fact that the medications were not helping and that I was deteriorating on them. While I was on these medications, I would have severe episodes of anger and would hit my head on the wall multiple times. I also would strip naked in front of my parents, scream my head off, rip out my hair, self-harm to the point where I would be completely covered in my own blood and laugh hysterically. This was all very difficult for me and my parents, and I had no history of any of these symptoms before. These episodes unfortunately continued for 4 years while I was on these medications. Next slide. During this time in my life, I also had multiple suicide attempts that landed me in the hospital. There was one time where I was put on lithium and I could not stay awake. I was sleeping for 23 hours a day, and I would only wake up for 1 hour around dinner time to get myself food, and then I would go back in my room and eat and go back to bed and sleep for the rest of the day. After 2 weeks of taking this medication, I had a suicide attempt and I overdosed on Tylenol. By the time I got to the ER, the doctors told me that I was probably going to end up on dialysis. My blood work showed that my kidneys and liver were failing. I was 20 years old and I was facing the fact that my life was basically over. Knowing that I was probably going to end up on a dialysis machine for the rest of my life was devastating. But after staying in the ICU for 3 days, I was thankfully able to avoid being put on a dialysis machine. They were able to reverse my liver and kidney failure, and I was able to go home without suffering any long-term health issues. I was so relieved. I also decided to stop seeing my provider after this event happened, and I went off of all of my medications. Next slide. After I went off of the medications, my symptoms improved, but I continued to suffer from severe depression and OCD. When I was 25, I was finally able to see a psych nurse, and I was finally diagnosed with ADHD. I was prescribed Adderall, and I noticed a huge improvement in all areas of my life as soon as I started taking it. I was finally able to stop self-harming, and my anxiety no longer controlled my life. It felt like I finally got my life back. But unfortunately, after my psych nurse at the time raised my dose to 40 milligrams, I noticed that it was no longer working. I brought my concerns up with her, but she dismissed me and said it was just my OCD. I felt like I could no longer bring up my concerns with her, and I stopped talking to her about it. A few months later, the clinic closed for good, and I lost my psych nurse. I now had to start having my primary care provider oversee my med management. I tried for an entire year to find a psych nurse after the clinic closed, but I couldn't find any specialist who would see me. They were either booked out to the point where they were no longer taking new patients, did not take state insurance, or they did not prescribe ADHD stimulants. I also waited for 6 months to see a psych nurse through the clinic where my primary care doctor worked, but the psych nurse refused to oversee my care and did not prescribe stimulants either. Then I realized that my medication had completely stopped working to the point where it was no longer helping at all with my ability to self-regulate. Next slide. When I first realized that my medication had completely stopped working, I paid almost $300 to see a psych nurse. It was very expensive, and she told me that I could continue seeing her, but that I would have to pay $150 for every visit. I knew that I could not afford this, so I had no access to seeing her. I also was told by my doctor that because of the state laws, I would not be able to get my dosage raised for 4 weeks. Next slide. During these 4 weeks, I experienced episodes where I would violently rip out my hair to the point where my scalp was bleeding. I also would have what appeared to be non-epileptic seizures multiple times a day. This was incredibly exhausting for me, both physically and emotionally. I was in a nonstop crisis, and I knew that there was no help available to me. Next slide. As the days dragged on, I experienced severe depression and suicidal ideation. It felt like I was in hell. Every time I tried to resist hitting myself, it felt like my body was on fire. I lost the ability to function in all aspects of my life. I felt that the system had neglected me because I desperately needed my medication, and I could not get it because of the way our state handles controlled substances. I would lose huge chunks of hair every time I had an episode. Next slide. After a week of going through hell, I started to bald. It was incredibly embarrassing, and I had to try to hide it from everyone. Next slide. I was so miserable in this picture. I just wanted it to go away. I became more and more distraught as the days went on. I was covered in bruises from head to toe from the episodes. Next slide. After dealing with these episodes for 2 weeks, I accumulated an enormous amount of hair, as you can see in this picture. I felt like the system was completely clueless about the harm these laws were causing me. I just needed my dosage raised. Is that too much to ask for? Next slide. Next slide. Next slide. Next slide. By the third week of having no access to my medication, I plucked one of my eyebrows completely off and shaved my head. Next slide. I was also covered from head to toe in cuts and had carved letters into my chest. Next slide. By the end of these horrible 4 weeks, I was finally able to get my dosage raised. I immediately started to feel better after I started taking it, and I am completely back to normal. I truly believe that what I went through was completely preventable, and I think that the way our state handles controlled substances needs to change. Our state is so concerned about people abusing these medications that they fail to see the impact it has on people who are not abusing it and need their medication in order to function in life. That's the end of my presentation. Thank you.
Anna, would you like to say a few words? You're on mute, Anna.
Jocelyn, I would like to thank you for your incredible courage and your strength and for sharing your story with all of us. Thank you so much I know that it's a really sensitive topic, and I just want you to know that you have touched hearts and minds, and I want to thank you again for sharing your story. So a little bit about Jocelyn. Jocelyn is a member of NAMI Walla Walla, and she is also a member of the NAMI Washington Public Policy Committee. She has been one of our strongest, most engaged advocates for changing our behavioral health care system. Jocelyn has testified and shared parts of her story with the state legislature during committee hearings. She's written letters to legislators, and she has helped push for positive legislation that has improved our system. So I want to thank you, Jocelyn, for all the incredible work that you do. And again, thank you again for sharing your story with us.
Thank you. I really appreciate it.
I don't have good words to add here other than Jocelyn, thank you. My chat box is getting filled with comments from CRIS members, including one that I want to mention from Michelle Roberts with the Department of Health, who is passing on their support to you for your bravery and for sharing your story. You've raised an issue that I believe we will likely be discussing as a group well into the future. So thank you for for coming today and for being so open with us.
Thanks, I appreciate it. All I want to do is improve this issue. I just want it to end. I don't want this to ever be a part of our system ever again. I want this to be a thing of the past. If someone needs their medication raised, they need to have the right to do that.
Well, that is an important call to action to all of us. So thank you, Jocelyn. It feels strange to go into another topic after this, but that is my job as your facilitator. So I'm going to bring us to our next topic, which is we have a presentation on the King County Crisis Care Centers levy. And today we have Kate Baber, who's the King County Crisis Care Centers Planning Director. Kate, I hope I'm saying your last name correctly. And then Michael Reading, our Chief of Crisis Systems and Services. And I'm going to turn it over now to Kate and Michael. And Chloe, I think you have the slides ready to put up.
Hello, everyone. Can you hear my audio? Excellent.
Yes, we can.
Thank you so much for having here, and thank you, Jocelyn, for sharing your story with us. I'm here with my colleague, Michael Reading from King County, to share about a new initiative in King County called the Crisis Care Centers Initiative. And if you go to the next slide today, please. We're going to cover a few topics. One, provide an overview of what the Crisis Care Centers Initiative is, share about the timeline, provide a planning update, opportunities for community partner engagements, and welcome any questions the group has today. Next slide today, and I will pass it to Michael.
Thanks, Kate. I also want to thank Jocelyn for her presentation. It energizes me to continue to do the work we do, especially as we think about these safe places to go, where maybe had we had more of these, hopefully we can continue to path improving the future in our crisis system. So I'm Michael Reading. I'm actually the administrator of the King County ASO, as well as Chief of Crisis Services for King County, and I'm a member of the CRIS Committee representing the ASOs of Western Washington. So why Crisis Care Centers Initiative? This is a concept that we started years ago, and these are some principles that help guide us. When we think about when families or people are in crisis, somebody needs someplace to go. Right now in King County, their only option is to go to a hospital. Prior to my time in King County, I've worked at the Crisis Line and Crisis Clinic, now Crisis Connections in Seattle, and many a time people are asking for help, and sometimes it's a matter of like, go to the hospital if that's what you need. And people generally don't want to do that because they know that's sort of like the worst case scenario. And sometimes things have to get worse before they get better. And we think about the better approach to crisis intervention, why not have a safe place for people to go, that they could go when they want, when they need it, and get the right help. So that's our intention with these kind of crisis facilities, is to really have that place for families to go when they decide they need to go into fighting their own crisis. Also, when we look at our first responders and law enforcement officers who are intervening in those crisis moments in the community, many a time which involve behavioral health concerns, their options are to bring people again to the hospitals or sometimes to jail. If officers, first responders had safe places for people to be brought to for intervention, where there are enhanced behavioral health responders, we could alleviate the system more and have a timely community-based response for officers and first responders at a crisis care center. Likewise, our mobile crisis teams, when they're out and about, responding to folks when they're being dispatched by our crisis lines or 988, and they're doing their best work to provide community-based intervention, support, de-escalation, crisis stabilization, protection to resources. Sometimes it's just not enough. And so likewise, if they need to bring somebody somewhere, right now in King County, it's a hospital. So better for us to be able to have these crisis facilities, mobile crisis teams also have that added layer of an immediate resource. I've mentioned hospitals many times. So right now, the hospitals get overloaded with people presenting with behavioral health needs. And so our vision in King County to have crisis facilities to be that place for people to go, hopefully we'll see a great diversion of folks going to the right place for the right need and not going to a medical setting for the hospital ED who be able to more readily attend to those more medically complex patients instead of behavioral health needs, where the crisis facilities could actually attend to that. And likewise with 988, being on scene, I love Sam's vision of somewhere to call, someone to respond, and a place to go. I think just that mantra has been sitting with me for the last couple of years now, and just realizing the gap in King County that we have places to call, we have people to respond, but we just don't have the place to go. So that's what kind of fueled all of this for us in King County as to why we need to create the crisis care centers. So this initiative has been started. Next slide, please. So the Crisis Care Center levy has the paramount purpose of creating 5 new regional crisis care centers. I'll describe what that means in a future slide. But currently in King County, we do have the Crisis Solution Center, which has 2 different parts to it. There's the Crisis Interim Services and the Crisis Diversion Facility, one with 60 beds, one with 30 beds. It's not an open access building. It does great work for stabilizing folks that are brought by law enforcement or diverted from hospitals, but it's the only place that we have right now in King County. So we want to obviously create more capacity and open our doors for folks to attend to when they're in crisis. I'll describe what that means in a little bit. Then there's also some supporting purposes to the levy in order to think about other capacity within our behavioral health system. We've realized over the last several years, since 2018, we've lost a lot of capacity in our mental health residential continuum by losing high acuity beds for community-based treatment. So back in 2018, we had 355 beds. Over the years, we've lost 1 out of 3 beds, and it's a significant hit to our mental health residential system. So one of the supporting purposes of the levy is to invest in the mental health residential system by engaging some capital dollars to sustain the programs that we still have in place, as well as to look at how we can expand our mental health residential system to get back to better capacity. And as a result, as you see in July 2022, we had an average wait time of 44 days for somebody to access a treatment bed, and that's just too long. So it's about capacity. So hopefully if we build it, we'll have better movement and better access to capacity for certain people that need that level of treatment. The other supporting purpose is to focus on the workforce. Currently, we did a survey in 2021 of our King County behavioral providers, which showed that their vacancy rates of behavioral health positions has doubled since 2019. And that's just a few years. And obviously these are like pre-COVID to COVID years, and COVID has hit us all hard in all industries. We're still feeling the effects of it by having high vacancy rates of behavioral health positions. So the purpose of the levy is to really look at how we can invest in things like apprenticeships, higher education, supporting continuing education, credentialing, training, and others, strategic ways of thinking about how we could tackle supporting the workforce. On the bottom here, you see the programmatically, the Crisis Care Center levy is primarily a capital initiative, but we're also looking at how operations could also be supported through about 40% of the budget. There's a link on this slide, which I hope you'll have access to. You can actually see the language of the full ordinance for the Crisis Care Center levy. Next slide, please.
Michael, I'm so sorry to interrupt you. Some of us are having a little bit of difficulty hearing you clearly. I don't know if you can move your mic a little. There, that's perfect.
There we
That's
go.
great. No worries. Thank you.
Sorry. Thank you for saying so. So we mentioned the 5 crisis care centers in around King County. This is a roughly formed map of what we're thinking about. It's not a perfect map because the North Zone, I know we have to fix this just to show that North King County looks a little bit different than what's highlighted there. But our intention is to have a crisis care center in North, South, East, and Central King County for adults, and then and which anyone can approach, but then having a specialized crisis care center that focuses on serving youth. So we'll strategically have them around the county. And again, the purpose of zoning where they're located is for accessibility, so that people don't have to travel too far. Law enforcement has something more locally within their jurisdictions. So making them accessible is going to be key to the success of the crisis care center and how we could support communities. Next slide, please. So this is there's a lot on here. I'll give you time to digest it as I just chat a little bit, but this is what we're thinking about as a clinical model for a crisis care center. There's going to be several components to the actual facility, whether it's one facility or a cluster of programs nearby each other. But as we continue to work on an implementation plan and then implementing come 2024, the reality of what they'll look like physically will start to take shape. But what we want to see programmatically is a 24/7 behavioral health urgent walk-in clinic. So again, it's no wrong door. We want to have a place for people to walk in 24/7 as they feel that they need to see somebody, or to access supports, help, intervention, at whatever level that they assess that needs to be. Hopefully we could help people in the moment and get people to get back home or back to their lives, wherever that may be. Others might need a little bit more support. And so another aspect of the crisis care center will be a 23-hour observation program, which will be, as we'll hear a little later on the crisis relief center license. That's what we're intending this part of the program to also be, so that people could be more in a fixed place within a supervised, supportive setting, with intervention and supports for a period of time in order to be stabilized and then go back to your life. If that's not enough of support for someone, they need a little bit further intervention. The Crisis Care Center will have a 14-day crisis stabilization unit attached for 16 beds for short-term care. We also want to build in some follow-up post-crisis care by doing some bridging work and navigation to other resources. You'll see on the side we have an interdisciplinary team of the medical staff, clinical staff, support staff, peer staff. All levels of staffing are going to be key to the success of this program. We also want to see a DCR going to be stationed on site, so that if that next option of involuntary treatment is needed, the DCRs will be easily accessible to the facility, also to the local community. Next slide, please. And then just a touch on our timeline. So I was fortunate enough to be involved in the planning of this from the beginning. Actually, years ago, I visited crisis centers in Arizona and other places, and saw the models of what those facilities could do, excuse me, to achieve stabilization at a less restrictive option. And it just made sense to me. And I came back to Behavioral Health Division and talked about how we need to do something more. So we created this ballot measure in 2022 to present to the King County Council, which through a lot of iterations back and forth, the county had approved that, which went to a vote to the public in King County last April, which passed by a popular vote. So that's brought us to the Crisis Care Center levy. Now in phase 2, 2023, that's where we're at now. We were so fortunate to meet Kate Baber, and so happy to be able to work with Kate, as well as Jennifer Winslow, the Deputy Director for the initiative, and Matt Goldman, who's our Crisis Medical Director. So the three of them are our implementation team, solely focused on creating this implementation plan that will once again go to King County Council for approval, which will lead us into 2024, phase 3 of our program, in which we will start to implement the plan. The intention in King County is not to have county-owned buildings or county-operated buildings, but the county will do a competitive procurement process to work with providers to receive funding to have capital dollars to stand up buildings, facilities, structures, and programs and operations, and so on. And then phase 4, 2024 and onward, it's a 9-year levy. We will be looking at full implementation and then ongoing quality improvement. Through this process, even to this date and continuing on, I've been so impressed with Kate and her team that have been so much doing community engagement. So listening to the community, to other providers and other types of systems in order to gather as much information so that we can put together the most thoughtful implementation plan possible. So I'll pass this back to Kate to continue to talk about that.
Thank you so much, Michael. Next slide, please. Okay, I'm going to speak a bit more specifically about the current phase we're in, developing an implementation plan. And since we have a statewide audience here, I'll provide a little bit more context of what an implementation plan means in King County. This is tied to our county legislative process. So the Crisis Care Centers levy, so this is funded by a property tax levy that will run from 2024 through 2032, requires, before any of the funds can be spent, the development of what's called an implementation plan. And that's what we're working to develop right now. An implementation plan is it's a high-level budget and policy document. And it will outline in more specificity than the ballot measure ordinance language, the strategies and activities that are allowable under the initiative, the timeline, and the spending plan. Executive Dow Constantine will transmit a proposed plan to King County Council by the end of the year. And then our council's Regional Policy Committee, which is a subgroup of King County Council, will review the plan, perhaps amend it, and then pass it. And then our county council will do the same. Once King County Council passes the implementation plan, then our team will move quickly to begin implementation, which will start with a competitive procurement process. An implementation plan, it's not going to have the level of detail that you would see in a procurement, that you would see in a program manual or a contract. It's at a higher level of detail. And this is definitely a long-term process, and those details will get more and more granular as we get direction from our legislative bodies and as the plan is approved formally. Next slide, please. So I'm going to provide just a quick update of what we're doing in the planning process around the 3 goals of the initiative. So the first goal being developing this new network of 5 crisis care centers, places for people to go who are experiencing a behavioral health crisis, a behavioral health challenge, and are seeking immediate assistance. 6 major activities. We're assessing capacity needs right now, refining the clinical model. So the ballot measure ordinance does require 3 major components: the 24/7 urgent care walk-in clinic, the 23-hour observation unit, and the 2-week stabilization unit. Thinking about what supplemental services, how to build those out, which will also be driven by regulatory rules through DOH and just budget limitations. Seeking community feedback about how do we ensure crisis care centers are safe and are welcoming to all community members. And we've gotten some really wonderful feedback and continue to engage partners to hear more about different perspectives. So again, refining scope of clinical services, supports, and wraparound services. Thinking about system partner coordination. So these are new capacity that are coming into an existing continuum of crisis services. And I see CRIS as a really important, and the state of Washington as a critical system partner to think about, to coordinate with. And then also thinking about the licensure and regulations that will regulate the crisis care centers. Next slide, please. All right, moving on to mental health residential. So we're again working to stabilize and restore lost mental health residential bed capacity in King County. We've been working to evaluate the continuum of residential services, working to engage with providers, partners, to better understand how we can stabilize the sector. Again, are planning to make some big capital investments to stabilize and prevent additional closures of current facilities that are operating, and then work to restore lost bed capacity. So we're looking at building back a minimum of 111 beds. Next slide, please. The last piece we're thinking about is our workforce. We cannot achieve any of this and all of the other critical behavioral health services that people in our community need without having a robust workforce. And so we're looking through workforce strategies through three different lenses. The first is thinking about what can we do to expand the behavioral health workforce, bring more people into the field, create more opportunities. I know this is absolutely not happening in a vacuum. I know this body is thinking a lot about this. Other entities and organizations at the state level and nationally and regionally are thinking about this as a huge issue. And we are also thinking about this and eager to learn from others and to think about how do we build the workforce in our community. And then, thinking about people leaving the field and what can we do to retain workers, to continue to support workers in building their skills, their professional goals, and seeing behavioral health and community behavioral health in particular as a long-term career pathway. And then our third goal is thinking about how do we increase the representation of our workforce. So ensuring that our behavioral health workers reflect the demographics, the experiences of people seeking behavioral health care in our community. Next slide, please. We have a lot of opportunities to engage community partners. That's a major focus right now, and we would love any of you or your organizations getting involved or sharing this information to networks that you're connected with on the website or on the slide, excuse me. I'll highlight that we have an email address, we have a website and a survey for people to share feedback. Our website has a calendar of events. We have 4 standing planning meetings, one related to just an overall implementation, an initiative meeting, community meeting, one specifically related to substance use services. So how do we make sure crisis care centers are able to meet the needs of people who use substances, who are living with substance use disorders, a work group specifically addressing issues unique to youth, and how do we make sure the youth crisis care center meets the needs of that community and those people. And then a 4th work group related to system integration. So how do crisis care centers, when they come online, how can they be well integrated and really complement the services that exist, be person-centered, be easy to navigate, and be a point where someone can easily access care, no wrong door, to really intervene and provide support that they need to get better. We have a number of focus groups coming up in October to connect to different communities, different subpopulations, and eager for anyone to engage who is interested. Next slide, please. With that, Michael and I are glad to respond to any questions or hear comments from the group. That is my last slide.
Thank you, Kate and Michael. I see some hands, and I also have some questions in the chat that came through from our CRIS members during the presentation. So how about if I start with a couple in the chat, and then I'll come to you, Jane. So the first question is from Dylan Nishimoto, asking which zone will the Crisis Care Center for Youth be? It was mentioned earlier in the presentation that there would be at least one. Can you tell us a little more, Kate, about your thing, or Michael, about your thinking about which zone that will be located in?
Sure, I can take that one. We don't know where the youth center will be located. We will be developing a siting and procurement process, and that will inform some of the parameters. So that will be forthcoming, and we're right now, the stage we're in is really listening to partners to hear and understand what attributes are important for the location or a location of the Youth Crisis Care Center. So that's something we're thinking a lot about, but do not have that finalized yet.
Okay, so it sounds like you're in the process of identifying the criteria based on the feedback.
Yep.
Great. Okay. Another question here from Dylan. In addition to full-time staff, would there be opportunities for trained volunteers similar to Crisis Connections?
Oh, that's an interesting idea. That has not come up yet. I think that would licensing might be something to look at. Are these settings where volunteers are permitted? I will take that back and share it with our medical director. I appreciate the suggestion.
Great. I'm going to go to Jane, and then I'll go back to some questions in the chat. Jane?
Yeah, and I'm really sorry I had to step out for a half an hour, Kate, so I missed most of your presentation. But just a really quick question.
Sure.
The crisis care centers, would this be an existing license designation, or are you thinking about asking the legislature to create something new? And the only reason I ask is because, and Representative Orwell knows this, is we want to, for purposes of private health insurance coverage of behavioral health crisis services, we list the types of facilities that the insurers have to cover services in. So that becomes relevant for this effort for you.
Thank you. I appreciate that question. These would operate within existing licensure frameworks that already exist within Washington State.
Great.
That's something we're actively researching and watching. There's some active rulemaking, which all of you I'm sure are aware of, around 1520, the Senator Dinger bill that passed this year that creates a new crisis relief center license. So that's happening. That rulemaking process is happening concurrently. So we're leaving that somewhat open-ended just to see where that lands, but anticipate that will likely be the licensing for the 23 observation, and then the residential facility for the 2-week crisis stabilization unit, and then likely an outpatient license for the urgent care center. Although it's really dependent on kind of where rulemaking lands and where any future changes with rules or state law. I really, Jane, thank you for flagging the private insurance coverage, and we're really excited about the implementation of 1688 and the opportunity for commercial plans to be able to cover some of the services offered in these settings in the future.
Thanks, Kate. A couple more questions in the chat, but first I wanted to just add on to Dylan's suggestion earlier about considering opportunities for trained volunteers. He added or volunteered opportunities for licensed mental health providers. So I want to put that in there. And then I'm going to go back up to a comment and question from Bipasha Mukherjee, another CRIS committee member. Hoping we can have other counties also have initiatives like this. Most important, how can we make this process work smoothly between King County and other counties as well, and state-based services like what we're working on with 988? So people in need don't have to think of where to go, but just call 988 and get the same standard of care anywhere they are. And that's the $1 million question, right? So I think that's more of a comment, but Kate or Michael, if there's anything you want to respond to there, I'll pause for a moment.
Sure, I can start then, Michael, if you want to add anything. I appreciate the comment. I think in terms of integration and coordination, I think that'll be key for the entire behavioral health system and crisis care centers included to have strong partnerships with other providers across the continuum, whether they're located in King County or elsewhere, and certainly with the state. So eager to coordinate and connect with partners. We have a work group around that, and I imagine that will continue to be a really important part of this initiative during its actual implementation in the future. Michael, is there anything you would add to that?
Yeah, I would just add, I agree with what you just said, Kate, but I would just add that, for the person in crisis who is geographically in that area, they will serve anyone. It doesn't matter where they're from, what their address is. If they're at the crisis facility, it is truly no wrong door. They can walk in, they will be served. I know there's other rules around, payments, but we'll figure that out on the back end. We don't want to make things more complicated for the person in crisis, but I think we have pretty well-defined systems in King County on how we, fiscally manage, behavioral health payment of services, work with the MCOs, with commercial insurance plans. We're working to figure that out so that truly it's no wrong door.
Thanks, Michael. Some more questions in the chat here. And CRIS Committee members, please feel free to raise your hand or send a chat if you have questions or comments on the presentation. This is another one from Bipasha. What is the role of lived experience and peers in putting all these plans into place? It is critical that they are being included. You can't build a system for the people without being part of it. If folks at King County can attend one of the lived experience subcommittee meetings to let the community know if and how they can be involved. BPAS should be glad to reach out to Michael on presenting this at a lived experience subcommittee meeting. All other counties who have services are welcome to present their sources to the community as well. So that's a comment and a question. Let me go back to just repeat the opening question, since that was a lot of content. What is the role of lived experience and peers in putting all these plans in place?
Great question. We are eager to engage with people who have lived experience and people who are our peers to help inform the planning process. We will have a peer focus group in October and would love to come and provide presentations, conduct listening sessions, focus groups with existing tables. I'll put my email in the chat and would be glad to coordinate with you. In the actual ballot measure language, so this is the law that is governing, peers are the only specific type of behavioral health worker called out as being required. So at crisis care centers, so there will be robust peer staff who will be part of multidisciplinary teams. So we really see the role of peers to be very, very important to the success of the initiative, and very important in helping ensure the centers are inclusive and welcoming and safe and feel like places where people want to go to receive behavioral health services.
Thanks, Kate. I have one more question in the chat, and then I see Dr. Snowden has his hand up. So the question in the chat is from Representative Orwell. Will the Proposition 1, meaning the Crisis Care Center levy in King County dollars, cover some of the operating expenses of the crisis relief centers?
Thank you so much for your question, Representative Orwell. Yes, we are planning to make sure that services that aren't covered by Medicaid or commercial payers will be funded by the Crisis Care Center levy resources. We are working, we really want to maximize Medicaid and commercial insurance revenues so that we can stretch the local dollars as far as we can. We know that not all of the needs in our community will be met by the levy. This will be a huge boost. So really hoping to and planning to really maximize opportunities with insurance to cover the operating costs.
Okay, there's a hand up from Dr. Snowden, and then I have another question/comment in the chat. Dr. Snowden.
Thanks, Jamie. My question has to do with the acute care beds attached to the crisis care centers and whether they will function as general ENT facilities, or are the beds really the purview and restricted to the use of the crisis care center only?
That is an excellent question. The 2-week crisis stabilization unit, it will not be an ENT. So this is a voluntary setting. Clinically seeing this as a step down from the 23-hour observation unit. There will be King County designated crisis responders who are co-located at the crisis centers. And that's a 2-part goal. One is so that responders are dispersed in the community and able to have faster response times to when they're called to respond to a person experiencing a crisis in the community. And then the second piece of that goal is so that if someone is potentially might meet the criteria for involuntary care, a DCR being available to do an assessment. If someone was to need a higher level of care, then the crisis care center would arrange somebody to be transferred to a different setting.
Okay, it looks like I have a comment here from Puck, a CRIS committee member. It's important to have peers there, but if peers need to be fully integrated into the workplace, I'm going to restate that. It's important to have peers there, but peers need to be fully integrated into the workplace for their presence to help. And then here's the question: how do we ensure that's part of it with these facilities? And I realize that's a broader question also for the CRIS, but Kate and Michael, any thoughts there?
Yeah, I fully agree. And that is our hope. And I think the place we're at right now is hoping and actively consulting with the peer community to figure out how to best do that. So would be really eager to connect with peers and peer groups to hear directly from people who deliver these services. Thank you for the question and the comment.
That appears to be all of the questions I have in the chat. CRIS committee members, any other questions or comments or feedback for our presenters today? Okay, and I believe these slides are already up on the CRIS committee website, but if not, we'll make sure they get up there so folks can review that again later, and there will be a recording. But I just want to say a huge thank you to Kate and Michael for coming and presenting this information. I think this is very timely, and we can take a lot from this this work that you're doing, and hopefully we can have you back in the future to hear how things are going.
That'd be wonderful. Thank you so much for inviting us to present.
And Kate and Michael, any final words before we take a break?
Just thank you for the work that this body, the CRIS committee, is doing. It's been really, really exciting to see Washington be a trailblazer nationally in expanding access to crisis care. And we're eager to collaborate with you and other state partners moving forward. So thank you for your work.
And I would just say that I'm grateful to be able to be on the CRIS committee from its beginning and the other crisis work that I get to do within the state system, because I feel like that informs me to do our best work in King County. So I'm grateful to all the learnings I have from all of you and others. I think we're on a path, especially with our leadership of Senator Dinker, Representative Orwell, of crisis champions, behavioral health champions, to really create the best system possible. So thank you.
All right, we're a little bit ahead of schedule. So why don't we go ahead and do our break? We'll take 10 minutes and then we'll come back and move into our system updates and then our discussion. So I have 1:47 on my clock here. Let's I'll round up to make it a little easier. Let's have everyone back on camera at 2:00 on the nose and we'll dive into the system updates. See you in a little bit. Okay, it's just 2:00. I'm gonna ask CRIS committee members when you come back to please turn your video cameras on so I know you're back online and I can get started. Great. Okay. All right, I think most CRIS committee members are back, so we can get started. Chloe, if you could take down those slides, that would be great. So now we're going to do our system updates. And just a reminder, this is, you received the monthly newsletter in the email package that Nicola sent out last week with the meeting materials. So hopefully you all had a chance to review that. And now is your opportunity to ask questions about what you saw in that newsletter. Before we do that, though, I did want to mention we have 3 new CRIS committee members, 1 person who's serving in an interim role, and then we have 2 newly appointed full CRIS committee members. Sean Ford is with us today, representing Emergency Medical Services, the CARES program, and I'd like Sean to just take a moment and introduce himself, and then I can say a little bit more about our other 2 CRIS committee members. So Sean, may I hand it over to you. And first, just want to say welcome. Thank you for being here.
Thank you. Yes, happy to fill in for a meeting at least. I am daytime job. I am the division chief of EMS for the Camas-Washougal Fire Department. And we are just starting our CARES team. We do have a CARES program that is countywide that we are part of in Clark County. And I'm also the EMS section chair for the Washington Fire Chiefs Association. So I work with EMS statewide on lots of issues, this being one of them, of course. So I was asked to fill in for at least today. So happy to be here and thank you.
We really appreciate you being here, Sean, and jumping in the deep end with us here. We have 2 other new CRIS committee members. And Nicola, if you're on, I'm just going to ask you to fill in any gaps here that I might miss. But Dr. Larry Wright, who had a conflict and couldn't join us today, but is joining the CRIS. Oh, you are there, Dr. Wright. Welcome. Okay. Can I put you on the spot and ask you if you wouldn't mind just introducing yourself to the group?
Sure. So apologies for being late. One of those days where meetings just run into each other. So I'm Larry Wright. I'm the Center Director for Forefront Suicide Prevention in the School of Social Work at the University of Washington. And I'm glad to be on the CRIS Committee.
And as you probably gathered from Dr. Wright's introduction, he is going to be here representing Center for Suicide Prevention Excellence. So, and then finally, we have Fennec Oak, who I believe was not able to join today. But Fennec, please wave your hands furiously if I have that wrong. And Fennec is a counselor, a transgender identified counselor who supports folks, among other things, in trauma-informed care. And Fennec is here representing our previously open position of an organization that supports behavioral health for LGBTQIA plus individuals. Thanks. Carrie's giving me a nod that I got the acronym. I got all the letters, so thank you. Yes, exactly. So Fennec, I believe, will be joining us on our in-person meeting next month. So that's exciting to have 3 new members, and we're so glad to have you here. Now I want to pause for a moment and see if any CRIS committee members had questions on the monthly newsletter, or if Michelle or Carrie have anything that you want to add or expand upon that was in the newsletter.
Well, hi, Jamie. I can go if you want.
Please. Sure, of course.
I did just want to highlight, sorry, I'll introduce myself for those who don't. My name is Michelle Roberts, and I serve as the Assistant Secretary for our Prevention and Community Health Division at the Department of Health. And that is one of our pieces is injury and violence and suicide prevention, including the state's oversight and administrative support of our 3 independent 988 call centers in the state. One of the things the 988 Let's State law has tasked the department with doing is adopting rules to designate crisis hubs as 988's crisis contract centers or contact hubs by January 1st, 2025. So that's taking our current 988 call center model and expanding to the additional types of services that are called out in the 988 state legislation, including referrals and triage for crisis counseling, next day appointments, dispatch, supporting dispatch from the organizations that have mobile teams and other pieces. So the next step in the state's rulemaking process is to do, we are having some rulemaking workshops. And there is in the materials that were sent out for the CRIS meeting, there are dates for those. They are in September. There is 2 broad community engagement sessions, and then there's 2 sessions specific for our tribal nations and tribal partner communities and Indigenous people to participate. So those information on more details about the workshops and information on how to sign up is in the newsletter or the 2 attached flyers. So just wanted to call that out.
And Michelle and Jamie, I would say I don't have anything specific to add except to kind of, I think, draw folks' attention to the newsletter. It's really full of a ton of, I think, updates. And just wanted to kind of, I think, give a little bit of a thanks to folks who really leaned in and helped the Healthcare Authority team with a lot of the best practice guides and some of the work that we're doing. And wanted to let everybody on this phone call know that Michelle Roberts and I had an opportunity while the Assistant Secretary of SAMHSA was in town for the National Tribal Opioid and Fentanyl Summit, which was hosted by the Tulalip tribes. Michelle and I had an opportunity to meet with the Assistant Secretary and just really talk about how things are going in Washington, and wanting to just let folks know that we have not only through our Native and Strong line, but just a lot of the work that's happening here, including the legislation and the putting it into effect, is gaining national attention and quite a bit of praise from the SAMHSA Assistant Secretary for the work that's happening in Washington State. So I just wanted to let everybody on this call know that I think is attributable to everybody on these calls participating, and just the dedication that Washington has to having a really great crisis system. So I'll just add that, Jamie.
I appreciate it, Carrie, and thank you, Michelle. CRIS Committee members, any questions, anything to add here before we move on? Michael.
Yeah, thanks, Jamie. So yeah, I agree, Carrie. This newsletter has been super helpful. It's so rich with a lot of information. I'm looking at this section on the Crisis System Technology platform. On our last meeting, I learned a lot. It was a lot of information that you all shared from the RFI. My question is, I imagine there's so much to digest from the RFI responses. Is there an anticipated timeline as to what the next steps are? You outlined the next steps, but like, what's the time frame that you're thinking about that an RFP might go out?
That is a great question. And Jamie, if I'm able to kind of maybe call in an SME from HCA who's on the line.
Yes, please.
If we do have, I know that maybe Jenny or Hoon or Kelly, if that is your name and you work for HCA and you know what this RFP is about, turn on your camera, please. You are the SME selected today by me.
And if there's nobody here, I can maybe say that I think we are not ready to commit to a timeline because there is so much information, like you said, Michael, there that we're still working together. And then lots of state government processes that both agencies are working through with our attorneys and with the state contracting office and everything to figure out the best path forward for an RFP, excuse me, because it's super complicated with 2 state agencies and lots of rules and lots of technology processes. So we don't have
Absolutely.
We don't have a timeline yet is the bottom line.
Exactly. I did see Jenny turn on her camera really quickly though. Jenny, any additional updates that you wanted to give to folks on CRIS today?
No, I was essentially going to say what Michelle said, echo that. There is a lot of work underway at present in defining the draft requirements, and we will be reaching out to NSPLs, RCLs, as well as internal people to help us review those draft requirements.
Good deal. Thank you, Jenny.
Well done with the pinch hitting there. So thank you. Any other questions or comments from our CRIS committee members? Okay. Well, we are nicely ahead of schedule here, so maybe we can dive into our discussion topic. Chloe, do you mind putting those slides back up on the screen, please? Okay, and I'm going to put a link in the chat in a moment too. So last month when we met in July, which now seems like a million years ago, we started working on exploring recommendations for addressing system gaps that we've identified throughout the year in our discussions for mobile crisis response. And we got through most, but not all of it in that conversation. So we wanted to finish that discussion today. That's what I promised you last month. And it's also important because it nicely sets us up for our in-person meeting next month in September, where we're actually going to get to be in a room together, and I think be able to do these things much more easily because we'll have whiteboards and flip charts and all the things that help us work together more effectively. So that's what we're going to do today. You should have received a copy of that PDF, that document that we were working on. It's like a matrix. You should have received a revised copy that incorporated all of your feedback from July in your meeting materials that came from Nicola last week. But if you're having trouble finding it in your inbox, and I know how quickly those things can get buried, I'm going to send you the link right now, because we also have it up on the website. So it's in, hopefully that link works. Sometimes these links don't work. I'm going to try one more time, just make sure it works. Well. You might have to copy and paste it in your browser. I'm going to show it on the screen as well, but I think it's going to be a little bit easier for folks to look at it locally because it's a pretty wide document. Chloe, if you could advance the screen, please. All right, so I just want to remind everybody what this document was as we're setting up this conversation. Our purpose of this document was to synthesize the gaps in the mobile crisis response system that you've been identifying in our meetings throughout this year, but also align those with our progress to date on addressing the gaps. No sense in making recommendations on things that have already been addressed or are work in progress. So that's part of what we were trying to do with this document. But then we also wanted to capture potential actions and opportunities to further address these gaps as identified by the CRIS Committee, the Behavioral Health Crisis and First Responders Collaboration Work Group that you remember we presented on at last month's meeting, and also the Lived Experience Subcommittee and HCA. And all of this will, oh, thank you. Thank you, Nicola. I actually put the correct link in, so I'm appreciative. This will serve as the foundation for the 2024 Steering Committee Recommendations and Progress Report that will be going to the legislature on January 1st, 2024. And it'll be used as a working draft for continued updates from the CRIS and subcommittees. So this is a living document, and we want to continue building it today. Just a reminder that this document is organized into the following subcategories. At last month's meeting, we went through data and reporting, dispatch, and capacity. And today we'd like to tackle equity and safety and system navigation and accessibility. Now, the document went out last week. I know some of you probably had a chance to look at it again, and some of you may not have. So I'm going to do what I did the last time, which is we're going to go first with equity and safety, and then system navigation, accessibility. I'm going to give you a few minutes to review the section we're focused on so you can refresh your memory, and then we'll start talking about it. And Chloe, if you could advance the slide, I'm going to remind everybody of the prompt questions that we're using. All right, so the 3 questions I'd like you to consider as you go through the document is, first, recognizing the progress that has been made and work underway, where are system gaps remaining? What are we still missing here that we have to get into this document? The second prompt question is, where can CRIS recommendations build on the progress by state agencies in the legislature? So if you're seeing some progress to date, but you feel like there's still things we could do better or differently that will better address these gaps, that's a great opportunity to make recommendations. And then finally, where are opportunities for the CRIS to advise and support state agencies in work to implement system changes? Clay, can you, I'm trying to think about how to best to do this. Are there any CRIS members who don't currently have access to the document I'm talking about? Can you just raise your hand if you're struggling to find that document? Okay, I'm going to take that to mean everybody has access to the document. So I'm going to invite everyone to look at page 4. That's the one we're going to work on first. It says equity and safety on that page. And I'm going to give you, let's say 7 minutes to review that. And we're going to leave these prompt questions up on the screen so you can remind yourself of what the prompt questions are. I'm going to give you 7 minutes to look at that document and think about your answers to the prompt questions. And then we'll come back together at, we'll say 2:23 and start discussing that section. Anyone have any questions about what I'm asking to do here? Okay.
Can you tell me the page number again, please?
Page 4 of that document. It says equity and safety at the top of it. All right, we'll see you in 7 minutes. You can feel free to turn off your camera if you need a little privacy. Okay, as people are coming back on, Chloe, do you mind taking down the prompt questions and putting up the document we're working with? I'm going to go ahead and just post those prompt questions in the chat to remind everyone. Okay. Well, I don't know if you can expand that a little bit so it fills the whole screen. I think that'll help people be able to see it. And I also have a question for me in the chat here from B. Pasha. That's a really good one I should read out, which is the Lived Experience Subcommittee Work Group got a document that incorporated feedback from the Lived Experience Subcommittee. That feedback's not included in this document from the start. And a question of why. And Nicola, please jump in and correct me if I have this wrong, but I believe we're going to be incorporating all of the subcommittee feedback on this into the next iteration that'll include the outcomes from today's discussion. So the version that we're looking at when we get together in September is a complete one that has feedback from the CRIS Committee and all the subcommittees, including the Lived Experience Subcommittee. Betsy, do I have that correct?
It will at least include feedback from the Tribal Subcommittee and Lived Experience.
Okay.
Yeah,
Okay.
we're in the process of integrating all of that feedback across the 3 pillars, and it takes time.
Okay, thank you for helping me out with that one.
You're welcome.
All right, let's see here. So I would love, now that you've had a few minutes, everyone, to refresh your memory on this document. I would love to hear what your thoughts are on the 3 prompt questions. Where are there system gaps remaining? What additional recommendations should we make to build on the progress that's been made to date? And where are there specific opportunities for us, the CRIS Committee, to advise and support state agencies in work to implement systems change? Anyone have any thoughts they want to add to this? Dylan.
Hello. Hi, my name is Dylan. I work with Asian Council Referral Service. So a couple of questions came to mind. Is one that I really did not know a whole lot about, but the Medicaid state plan when it came to billing. We are trying to navigate this on the agency level here, but the definition of mental health care provider has the educational requirement of minimum of BA level related field, AA level with 2 years of experience in the mental health or related fields. I'm curious about what that would mean in terms of billing, especially for folks that in lived experience and peer supports, because education, a traditional education environment is not why they're being called into action for this. So that's a really big one for me, and I know that I'm looking at that for our work. And then the other part I was thinking of were the many people of color and those that identify as LGBTQIA+, and the lack of trust in those systems. I'm thinking to the aspect for suicide assessment and how that became a requirement for folks in this journey. I'm thinking as the training and requirements for gender affirming care. And I know there's other stuff in there around trauma-informed care, but where else we can sort of fill out that so we can learn to trust and build trust in the system that because it's not just the system we're trusting, we need to be able to trust that the providers we're talking to are going to be able to treat us with respect and care.
So Dylan, I just want to make sure I'm tracking. So it sounds like you're reading, you said from the state plan. Is that what you said?
The Medicaid state plan.
The Medicaid state plan, okay.
Yes, and so there are probably many others on this call that are much more better informed about this than I am, but this is something that I know that we're trying to navigate as an agency for our folks that are peer supports and AAC level folks that do not have BAs or meet some of these other formal educational requirements.
Okay, so it sounds like the concern you're raising is that with some of the things we talk about here about making it more accessible for peers to be involved to build that trust and address equity for both people of color and people from the LGBTQ plus community, that some of these requirements in the Medicaid plan could be counterproductive or might need to be addressed.
Yes, counterproductive and also not very congruent with the idea of what my understanding of a peer support person is.
Yeah. Okay. So probably what we're talking about is the system, is this is a system gap that we may need to think about some recommendations down the road for how to address it. Thanks for raising that. Let's see, I've got a couple in the chat here. All right, and Bipasha is sharing notes made by HMA on the lived experience feedback. So I'm going to share a few of these and then come back to it, but a couple hands up. So additional themes from the lived experience subcommittee. I think this, I just want to make sure this falls under system gaps. People who will not call 988 due to fear of police engagement. Experiences that are further traumatizing when people call for help results in inability to get and it results in an inability to get services and loss of faith in the system. Lack of standards and standardized training for determining who receives what response and why. Bias impacts determinations about who gets what response, particularly for Black, Indigenous, and people of color and LGBTQ plus populations. And then experience and stigma associated with having a behavioral health need. Implicit bias that behavioral health condition is a choice rather than a brain-based illness. And I'm going to go ahead, this is a lot to take in verbally, so I'm going to go ahead and copy and paste this in the chat so everyone can see it. I think some of these, Nicola, correct me if I have these wrong, but some of these might be incorporated into other parts of this document, but my brain may be missing that. I see a few hands and then I'll come back to the chat. So let's go with Kashi.
Thank you. Kashi Arora, she, her pronouns. I work at Seattle Children's and I represent the child and youth seat on this committee. And I actually wanted to say something sort of similar to what Bipasha just shared, having the gap on the far left being about concern from community about engaging in the crisis system for a fear of sort of law enforcement or first responder involvement makes me also think about the co-location pilot that was discussed in the newsletter. And I may be missing it, but I don't see that reflected in the future actions either for agencies or legislators or for CRIS. And so I think that's something we need to rectify by making sure that a co-location pilot is noted here as a future action and that there's intentionality around it, because the gap listed on the far left is existing concern about engaging in this system, and then the plan is to co-locate them. And so I think that could perpetuate some of those concerns if it's not done with a lot of intention and messaged with a lot of intention. So I would like to see that reflected here. Thank you.
Okay, so listing the co-location pilot and acknowledging that it has to be done with a lot of reflection and intention, understanding that it's there to address these specific concerns that were identified in system gaps.
And I think we talked about this in the last meeting, but that might actually support the more appropriate calls going to 988, because I think one of the persistent concerns from community has been, I'm going to call 988 and get triaged to 911 and get police when I wanted behavioral health support. And so I think we have tried to do a lot of work to separate 911 and 988 in people's minds, and then to put them in the same physical space. It's just really important to communicate to community that we actually think that may increase the success rate in getting the people who need behavioral health response to the 988 response. And that's critical.
So making sure people understand the true why behind the impetus to do the co-location. That's a really important point. We'll make sure we add that when we move that over into the future actions. Darcy.
Hi there. So I think that when I look at the topic equity and safety, and I think that the sort of get around this and some of the potential interventions along the worksheet, but we also the safety of the mobile crisis responders and their sense that they're going to be safe when they respond. I think that does. I know that gets in the way, and police often get called because there isn't. They don't feel confident that that they're being sent out to someplace and they're going to be safe when they respond, and so we see the domino effect of all kinds of bias and fear and worry. And so I do think we need to call that out as a potential gap.
And Darcy, I actually think just refreshing my memory, I think that might also be a theme that showed up elsewhere in this document as a gap. So I hear
Yeah,
you
I
that
think
it
it's in
could be
the-
relevant here too.
I think it's in the dispatch.
Yeah.
And but I do think we do want to recognize that safety is also for the responders.
Okay. Yeah, that makes sense that could also impact the equity outcomes that we would like to achieve. So thanks for raising that. Michael.
Thanks, Jamie. Sorry to find the mute button. The thing that strikes me as I read this, I mean, I think that the gap we're identifying, the lack of trust with specific populations is real. I mean, I've seen it in action. I totally agree with all the strategies that are being identified, like training, trauma-informed approaches, Bill of Rights, peers, inclusion of peers. I guess as I'm reading it, what strikes me is we're thinking about strategies on the helper end, but how does the helpee know that? How does that actually change the level of trust? So I guess what makes me wonder is like, I don't know, is there media campaigns so they actually show people somehow that we are trauma informed, that we are safe, that it is safe to ask for help? And I'm just almost in my mind, I'm almost creating more of a problem out of it than maybe it is, but it just makes me feel like there's two sides to the story. So trust goes both ways. So we could do everything we can to try and build trust, but unless it's received, how are we making a difference?
Michael, you're bringing up something that we've heard consistently over the last few meetings, which is all this progress and effort is important, but it's also going to be really, really important in how we communicate with community members. So that, and I think that echoes nicely what Kashi was just saying about how we need to make sure that people understand what the co-location is intended to do. It's not intended to send people to law enforcement. Thank you for raising that. And it sounds like we need to add that as a system gap here as well. I just want to pause. I see a lot of hands up from CRIS Committee members. I just want to pause for a moment because Matt Gower was reflecting on the comments from Dylan, or the comments from Dylan earlier, mentioned there's a state plan amendment we're hoping to get into place in January that will allow for peer support to encounter services just as a peer. So that's good information to have. Next up is Representative Orval.
Thank you. This is a great discussion, and I just couldn't agree more with the comments that have been shared so far. And I do think with the co-location, and yes, the intent is to build relationships between 988 and 911 so we can get more calls over to 988. And clearly a lot of mental health calls come in, but I do think, DOH has money to promote 988, and there is an opportunity, like Michael said, to maybe describe the vision of 988. And I think part of the mobile teams is we do want them to be culturally sensitive and informed and to be clinical whenever possible. And like, how do we convey that in a message? It's kind of hit me working on this that, we often do partner with EMS and fire, and there probably is a lot more training needs around behavioral health and cultural sensitivity that we can be doing with them, because they are going to be part of our front door crisis system. So these are great comments. And I feel like we have a little window to really get this right before people start making assumptions about 988.
I agree with all of the points you just shared, Representative Orval. And I think we have some, based on the comments, this string of comments, so I think we have some adjustments we can make here in both the system gaps column around how we communicate and what we communicate, and then maybe some recommendations. Senator Dhingra.
Thank you so much. I always love the discussion parts as well as everything else we do here. Michael voiced something that I was debating how to articulate at this meeting. As many of us are out and about across the state talking to people, this trust issue comes up a lot. And to me, when we're talking about doing a color bill of rights, to me, that's an opportunity where it's not something that we as this group should be developing. I would really encourage us, and I am sorry if I'm going to put the lived experience group out there, but I would love to see if they can take lead on it and not just do it within their group, but really be the ones who go out into community, go out into organizations and talk about a color bill of rights and get the initial draft of what people would like to see in that come from community, because we cannot build trust if we're putting things out and asking people to adopt it. I think we have to reverse it in this extent, in this arena, and go out to community and say, please tell us what you would like to see as your Bill of Rights, and start there and have them start the conversation. And then we work on it to see what we can do as the government or as agencies, or as people in power to try to incorporate their voice into this. So I think there is a great opportunity for us to engage differently and elevate the voices of those individuals who are fearful of the system, and see if that is one way in which we can build that trust.
I'm seeing a lot of echoes of what you just said, Senator Dingra, in the chat here. There seems to be some desire to get out to communities. I think the challenge I'm seeing raised by Bipasha here is how to do that, where are the resources to do that. So that's probably something we need to do a deeper dive into talking about, is if we want to really meaningfully engage with communities on what this Color Bill of Rights looks like, what our starting place is. We need to think about how we can do that given the limitations we face. Senator Warnick.
Thank you, Jamie. And I just want to add in, this is a very good discussion, like Senator Dingra said, but I have heard a lot of different groups, cultural groups referenced, but I haven't heard anything about our rural and agricultural folks, and that might be in a different spot, but talk about people who are afraid to call. They're not necessarily afraid of being engaged with law enforcement, but they are afraid that they might not be really heard, because it is a different group of people out here in the rural areas. Very prideful, very proud, and to think that they might be tagged as having a mental health crisis or a mental health issue is hard for them to admit. So and we have cultural differences here too. We have our Hispanics, we have our Russians, we have our Ukrainians in my little district in Eastern Washington. So just don't want to leave out the discussion on our rural folks and the differences that we encounter out here in the rural areas too. So, but good discussion.
Thank you, Senator Warnick. So it sounds like we need to make sure that we're being inclusive in our language here, and making sure we're not just capturing the groups that are listed, but also addressing that folks in rural areas have specific fears that might be different and might need a different approach to addressing them.
And
Thank
Jamie,
you.
we are, Senator Warnick, we are working with the Rural and Agricultural Subcommittee to get some feedback and provide some input. We're doing yeoman's work to get all of this feedback back incorporated into the synthesis document. So thank you for raising it, and point well taken. We are working on that.
Thank you.
Yeah.
Anna.
Hi, yeah, I wanted to address the bullet point for says including law enforcement and other partners in trauma-informed and youth-informed trainings. And I just wanted to bring up how, how is our CIT, our crisis intervention training for first responders and law enforcement integrated within, is that something that's going to be integrated within our 988 system? Because, especially going back to Senator Warnick's statements on, rural mental health, the feedback that we're receiving here at NAMI is that if somebody from a rural community calls 988 right now, they are more than likely going to get a law enforcement response. And seeing as though, that's the case now, and it's going to take years and years of development and funding to really expand our mobile crisis unit. I know our goal is to mitigate police response, but for now, this is the system we have. This is the system we have to work with, and we're slowly, change is always slow. I guess my input is I'd like to see some standardized training within crisis intervention training for law enforcement to make sure that they really do integrate culturally sensitive, linguistically appropriate services. And, I've also spoken with with people from our CIT, and I'm hearing that the training isn't standardized. It's different depending on the county or the region where the CIT training is taught. And I understand the need to modify the trainings to make sure that they fit the needs of the community, but we should also have some strong standards to make sure that the law enforcement are properly trained to de-escalate the situation and to be more sensitive to the fears and the needs of the communities. And so that's just something that I wanted to bring up. Also, I love this whole talk about the caller's Bill of Rights, but unfortunately what I've seen in a lot of Bill of Rights, quote unquote, legislation is sometimes they'll get passed and then it just ends up being a performative act. And I just want to make sure that if we do implement a caller's Bill of Rights, that it actually implements real change. It's not just something that's performative, but something that's actually going to bring systemic change.
A lot of good points there, Anna. So it sounds like in the sections here where we're talking about training, you would like to see some more specifics here around having some standards that go across communities, and then an acknowledgement that there might need specific tailoring to the needs of an individual community with that training. But recognizing that it's going to be in many places years before there's the capacity to serve people in crisis with the kinds of systems we're trying to implement. We still need to, you're saying that these trainings are going to be really important for law enforcement to make sure that we're providing culturally competent care. So we can definitely get that in there. And then I think it sounds like you'd also like some more specifics around here about this Bill of Rights being more than just a performative piece of paper, but something that actually translates to some substance in how we approach serving callers.
Correct. Yes. And as far as the training for law enforcement, it's really more getting specifics. We currently have the CIT training, the crisis intervention training that's being taught in different communities, King County being the biggest hub. But I just really want to make sure how that's tying into our, the development of our behavioral health crisis system, and seeing those changes implemented within CIT.
Okay, I think we've got some good stuff to add in here on that. It sounds like maybe also some evaluation. I think you mentioned something about actually looking at how these trainings are playing out in terms of outcomes. So looking at some evaluation. And there's an echo in the chat from Kashi echoing Anna's comments. In addition to adding law enforcement to new trainings, we should be updating existing law enforcement first responder trainings to reflect best practice for engaging with those experiencing mental health issues. The difference between asking them to come to us versus going to where they are. Bipasha.
I'm just going to tie in a few points that were brought up, Senator Dhingra. We are more than happy to do the work if we have the resources to do it. We've talked as the Lived Experience Subcommittee about how we have these meetings, but we don't go out to people. And I was having this discussion with HMA, and Michael Anderson-Nathy brought up an excellent point, which is there might be some data already in different agencies about what people want. And so it's just that the data may not have been looked at with the attention it needs, which ties into what Anna said, which is we sometimes collect data, but we don't do anything meaningful with it. So that's really important that we work on. I'm willing to travel across the state if it's necessary or connect in any way. And I wanted to tell you, Senator Warnick, at our meetings, we do hear from people in Eastern Washington. You heard from Jocelyn today. She's from Walla Walla. We're trying really hard to reach out to all communities that are marginalized, and that includes the rural and agricultural communities too. So whatever we can do to have the resources to reach out to as many populations to really build a solid, we don't like the term, but just as a placeholder bill of rights right now. And again, heartfelt requests that came from Anna and Kashi, that to make it meaningful and not just, lip service to the process. So thank you very much.
Thanks, Bipasha. I have a couple of comments in the chat from CRIS committee members, and then I'll go to Puck. Marie says, education and training must include intercultural competency and the understanding of our different attitudes regarding mental illness in language that doesn't cause more harm. Yes, absolutely. And then from Sean Ford, our newest interim member, EMS, emergency medical services, and law enforcement are continually tasked as the initial responders for each community urgent/emergent need. It must be recognized that we are likely nearing the situation where there is no bandwidth for first responders to take on more expectations with an expectation to be competent and well-versed. We have thousands of hours of training each year when you account for all the areas of responsibility we are expected to be proficient. So I hear this as a kind of counterpoint or caution around with the conversation we were having about the CIT training that Anna was bringing up. Let's see, I know I missed one. Okay, from Puck, it says, if suicides happen without engaging the system, why? Can we respectfully research this? So it sounds like doing some root cause analysis there to understand why this is happening and maybe start listing that in system gaps. And Puck, I think maybe you have more to say on that, so I'm going to turn it over to you.
Yeah, root cause analysis, but like literal forensic research, I guess. Like it's a thing, but like for all of my friends who have died, I would love it if the state had a very gentle, competent person to go in and have a conversation with people close to them and hear about their perspectives of the crisis system and where it assumably harmed them. I feel crazy even just talking about this, but like if we have communities that are not engaging with the system because they don't feel safe engaging with the system, and we know that, and we keep having this system, and we're talking about trying to have equity in this system, but we're still using a system that involves non-consensual choices. It involves bringing out intervention when people don't want it. Like, yeah, absolutely, active rescue is important and it's great and it has saved people, and I am grateful for that. But I wonder if it's saved more people than it has harmed. Because that's often what is keeping people from engagement. And we don't have numbers on the people who don't engage. And so that's the part where maybe we look into that. Maybe we start questioning, where have we gone wrong in this crisis response thing, that so many of the people that we're alluding to when we talk about equity don't even feel safe beginning to engage with the system. Like, clearly those people aren't benefiting from active rescue or whatever is bringing out these people that are not safe for them. And that feels really terrifying to say, but I think it's something that we need to look at. And it's something that I think I'm trying to gesture to with that Bill of Rights stuff too, is like, what are the rights that we expect as people who call a crisis line, or as people who call a crisis line on the loved one? Like, do we expect that it's okay for them to have things happen without their consent? Have we now decided that we know more than them and feel safe calling unsafe people to try to keep them alive? Like, I've lost so many people. I'm absolutely not saying don't help people, but I'm saying, what if the way we're helping people is not working? Because I think that's why we're here, because a lot of us recognize that it's not working. But it feels like we're still trying to build the same system and just say, give people more cultural competency trainings. And that's not going to help.
Please tell me if I'm hearing you right or wrong, but what I'm taking from what you're saying is we're throwing a lot of ideas at this board, but we don't have a really clear sense of why people are still losing their lives. And until we really understand that, we're not going to know if the interventions that we're proposing are going to help or hurt.
Yeah, because we can't ask alive people what isn't working in the crisis system for them, because it's still working as badly as it's working. It's still working for all of us who are alive.
So I'm seeing here like a system gap being, we don't really understand why some people are still losing their lives. And we need to understand that. And the recommendation can be around doing research in a sensitive way. And I have a comment here from Kashi that might be able to help illuminate in a sensitive way to start to peel that onion. And what Kashi says here is there are child death review forums in some counties, like what Puck is describing. King County's is newly called Child Mortality Prevention, and we meet at least once a year to review youth suicide deaths with the goal of identifying prevention strategies. Maybe a death review forum statewide is needed for suicide. Thank you for engaging on that topic. I think that's something we probably need to add to this matrix, so I appreciate that. Michelle.
I just want to really thank Puck for their comments and some of what Puck is talking about. Not everything, but some is available, and I would love to engage Puck and others, or maybe the Lived Experience Committee, to talk about what types of data is collected and what we have. So Kashi mentioned death review. So there is a number of different types of death reviews that do happen and have people with lived experience and different system partners on those committees. We also have something, and sorry about kind of, I guess, caution warning, this name is hard as well, but we have something called the National Violent Death Reporting System, which is housed out of our teams here at the Department of Health, but does a forensic analysis in some ways, looking at lots of different records of doing a deep analysis to look at trends and prevention in those deaths. I don't think, Puck, we have exactly what you're getting to around some of the interviews in the systematic way, like you're talking about, especially with loved ones left behind. But I'd love to just dig in a little more, and if others, about what we do have, and think about, are there opportunities to do more, and where are we missing? Because there is lots of different death reviews that happen, and so we could talk about which ones we have and which ones we don't have, and can we work on gap analysis together. So really thank you for raising that. And I think we're not doing enough as a Department of Health to talk about what we're learning through those systems, especially some of the more qualitative type of data. So I'm taking your comments too as a charge to us to do better about how we're using and talking about the data that is collected. So thank you.
I have a few comments in the chat along these lines, but I suspect Senator Dingra is going to be jumping in on this topic too. So I'll go to Senator Dingra and then I'll read some comments in the chat.
Thank you, Jamie. I did put my comment in the chat, but I decided I'll just speak. Puck and I electronically chatted about this a month ago, and I just wanted to share the thoughts I had at that point in time. And I'm hoping this is where we can get to, right? Because we really want to understand who are the people who are not accessing the system and what's happening to them, as well as taking a look at the people who are accessing the system and have negative outcomes. And so, I think what I would love to see personally, and we can expand on this, is take a look at like maybe 5-year period. Take a look at the number of attempted and the number of completed suicides, and then really take a look to see what is the type of mental health interventions or contacts these individuals had 3 months prior to this incident. Do we know if they called the DCRs? How many times did they call them? Do we know if they called 911? How many times did they call them? Did they engage in community mental health? Did they go to an emergency room? And I think that's going to tell us a story, right? Did they reach out for help? And do they have this history of reaching out for help and yet still having a completed suicide, versus they reached out for help and guess what? We actually didn't see the completed suicide. So I do think that there is data we can take a look at to see at least an initial story that we can glean from it, and then maybe do a deeper dive on it. But Puck, I just wanted to share, I think that's what we had talked about electronically. But those were my thoughts on like the first step on how to do this work.
Thank you, Senator Dingra. And Puck added in the chat, and if they weren't engaging in the system, what help were they getting? I also just put a link from Michelle Roberts into the chat. It's a link to the Washington Violent Death Reporting System. And then in the chat, I also see, this is from Carrie Waterland, HCA, maybe we can ask research and data analysis team from DSHS to come and present on what data is possible too. They do most mental health treatment data in Washington State. So it sounds like there might be some opportunities here to start to dig into Puck's recommendation. And then Betsy says, this is important content for us to consider also next year as we work on system goals, outcomes, and key performance indicators. So that's what I have in the chat. I see Michelle's hand up.
I forgot I was going to say something else slightly related, but to comments of others on a different topic. I see a lot in here about working with those that have disproportionate impacts in our communities of color and others, rural communities, LGBTQIA+, and other groups. But I just think, and maybe I don't have the right language at the top, but I think Carrie and I teams could work together. I think we could better identify our state commitment to centering people with lived experience and centering communities, and some of the ways we're trying to change the way we do our work as state government systems, recognizing that our systems have trauma and impact, and by trying to change just the way we approach our work, we're trying to find ways to undo some of that. So I just am saying here in this table, there's probably an opportunity to talk about state government's commitment to being pro-equity and informed more directly than I'm seeing here beyond. I think we're acknowledging the harms and some of the problems in this document, but I don't see quite as strongly enough our commitment to trying to change the way we do work.
So Michelle, it sounds like a potential future action is a deeper, more explicit commitment to changing the way we do work. But I'm also hearing, I'm also hearing just a common theme across this conversation of wanting all of that to be tied to actual data and understanding of the problems we're trying to solve, rather than either, as Anna said earlier, things that feel just performative or just throwing spaghetti at the wall to see what sticks. I know we're getting shorter on time and we still have one more page, but I also feel like this is a really important discussion. So if we need to take up more time on this one, we will find time in the future to do the last page if we need to. I also don't see anyone signed up yet for public comment. So it may be possible that I'll be able to buy us a few more minutes for today's conversation. And then finally, before I go to Dylan and Puck, I want to acknowledge that there actually are a number of chats here from community members. Community members, I apologize that I am not reading your comments. There are a lot of them here. Unfortunately, I need to focus on just CRIS Committee. We just don't have the time to incorporate all the other comments. That said, I am going to be saving this chat. We will be sharing these comments with CRIS Committee members, and hopefully many of you will also be attending lived experience subcommittee meetings or other subcommittees and sharing your input there as well. So I just wanted to acknowledge that I'm hearing from a lot of you, and I wish we had another 3 hours so that we could dive into all of the great feedback that we're seeing here. I have some also comments in the chat from CRIS Committee members, but I want to go to Dylan and Puck, who have been very patient. Dylan.
Well, again, thank you. Around the data of of finding out who are not reaching. I'm thinking about some of the Quality Improvement Committee from King County when they're looking at service penetration. I think one thing they're not looking at is actually disaggregating that data to figure out who is not being served. Because we know how many people are around, but we don't know who we're not getting to. Although we kind of do, but I think data's hard, and I think we don't want to be over reliant on it, and so finding things like focus groups and finding other means to be able to dig deeper into the story.
So I like the idea, Dylan, of looking at the quality improvement data and who's not getting served. I think you make a really good point about how quantitative data also needs to be supplemented with qualitative data. And I think Puck's original proposal about finding a respectful way to talk to people who might have insights is a really good way of supplementing the data that we're pulling together. But I really appreciate also the creative thinking that everyone's doing here about where we might start to uncover what's happening here. Puck.
And I guess I want to highlight that qualitative data needs to be culturally respectful as well. We need to make sure we're asking the people who are relevant, and that's hard to know. And that's, you might go to family and not get pointed to the actual people that you need to ask. So that's a big investigative process, I think, if we are going to commit to trying to learn from people who end up killing themselves. The other thing is that as we talk about that equity piece that we want to be, and as we talk about turning toward the lived experience and learning from that, we're still not being compensated. We're still disabled people who are volunteering, who are giving a lot of time to this. So I'm just looking at the equity Let's Compensate Lived Experience Volunteers bill, and the fact that that came into effect officially in January, but previously last May. And we've been asking about this for the CRIS process, and that hasn't happened. So I just think that is a small demonstration of a bigger systemic issue where we talk about what we want to do and then we don't actually do it.
That's a good reminder, Puck. Thank you. I just want to note, Betsy reminded me, no, we actually do need to get all this done before September. So I am going to get through the last comments that we have here and then hopefully turn us to the last page. And if we don't get through that, we'll do some exchanging with all of you via email between now and September. Carrie Waterland from HCA says, anyone can reach out to the Dakota Steele at HCA's Office of Recovery, to Dakota Steele at HCA's Office of Recovery Partnerships. He actively seeks out voices at individuals with lived experience. Carrie can drop his email for all, so I'll look out for that and send it all to you. Michael Redding from King County says ASOs are required to connect with MCOs regarding crisis contacts in order to support care coordination efforts. Much of this is done by looking at daily crisis contact data per individuals, like Senator Gingras noted. Will there be any effort put into care coordination for those contacting the crisis system with 988 who also intersect with mobile crisis and other crisis services? I'm just going to repeat that question. Will there be any effort put into care coordination for those contacting the crisis system with 988 who also intersect with mobile crisis and other crisis services? Anyone have an answer to that question from Michael?
I thought part of our bill required the follow-up. So everyone who calls 988, regardless of whether they have a mobile response, have to have follow-up. And if they have a mobile response, they absolutely have to have follow-up as well. And this is part of the mandating the next day appointments as well. So yes, we definitely want to know if that's not happening.
Thanks, Senator Gingras, for jumping in there. Okay, I think that's it for this page. That was a robust conversation. Let's get to the last section. Chloe, can you just advance it? I'm going to remind everybody when we're covering. Okay, so we're doing system navigation and accessibility. I'm going to ask Chloe to take this down. This is the last page of that document, page 5. I'm going to ask Chloe to take it down and put the prompt questions back up. And in the interest of time, let's just do 5 minutes here. If you could please spend between now and 3:12 reviewing that section and thinking about the prompt questions. We'll come back together and we'll get through as much as we can before we run out of time today.
Jamie, can you say which section again? We're back to the table.
Yeah, it's the last page of the table.
Okay.
And the heading on it is System Navigation and Accessibility. And these are your prompt questions on the screen here. Okay, CRIS Committee members, if you're ready, please turn your video camera back on. And Chloe, could you please put that last page of the document up on the screen? Great. Okay, so CRIS committee members, based on those prompt questions, any thoughts you'd like to share? I'm just going to put those prompt questions back in the chat so they're easily accessible for you. Any thoughts you'd like to share on this particular section? Kashi.
Thank you. I am looking at the gap on the far left and thinking about the gap being how hard this system is to navigate. I think to me is actually two different questions. One is how do we make the system easier to be navigated? And the other is how do we make the system work more effectively together so you don't have to figure out how to navigate this massively complex thing. And I think those have two different sets of solutions. And so I would love for the future action section to be reflective of actions that address the first issue of how do we make it easier to navigate this system, and the second issue of how do we make it less complex. And so the first to me is about communications to the folks who are utilizing these systems, the people who are calling, the families and caregivers and loved ones of those who are calling, communications, training, supports. And I think specifically that action item of centralized information and education about who to call, I would love to see that sentence continue to say, and what to expect from those resources. Like why, who do you call and why? What do you get from 911? What do you get from 988? What do you get from a regional crisis line? What's the expectation? If you're calling because you want to have a conversation with someone and feel heard and supported and de-escalate, there's maybe a different resource for that than if you are calling to schedule a next day appointment. Maybe it's the same thing. And so how do we talk to people about that? Of how do we make the system work more effectively together? I would love to see some actions in here about not only the technology integration that I think is sort of mentioned in the progress to date, and that's the place where I feel least competent to speak, so I will sort of leave it at that. But the other element that I have a question about is something long discussed, but I don't know has ever come to fruition, is some sort of inpatient bed tracking situation, like the administrative burden of trying to figure out who needs inpatient capacity or where appointments are or who actually has openings. You know, I think inpatient is a really specific example, but we do not have a way to say, here's the capacity on our system and here's how I would easily slot you in tomorrow if you wanted an appointment. And that seems like something the system could be doing to be made easier so that you as a parent don't have to become a case manager to get your child or loved one or other adult the services and supports that they need.
Okay, I really appreciate that framing too. So going back over this with the lens of separating those two questions of how we make this existing system easier to navigate and how do we build a system that's much less complex and easier. And you had some specific suggestions that we can put in the recommendation. So thank you for that. And Puck says in the chat, that's the thing. Individuals having to be case managers is exhausting. I hear that. Bipasha.
First I want to thank HMA for taking the time to really document all our lived experience subcommittee meetings and incorporate them into the CRIS process. It's important that the community feels that what they're sharing is being heard and being utilized. So I just want to read out some of the inputs they gave under this that HMA has recorded. In the leftmost column under gaps in mobile crisis response system, the lived experience shared, there is a lack of understanding and relationships across systems within the community, and that callers will often experience receiving response that their situation doesn't meet the definition of a crisis, or the response to the situation is not their job. And on the right-hand column, this sort of echoes what Kashi just said. There's input on developing a centralized, user-friendly database with all services in Washington. This resource could include information about services, meetings, job opportunities, and other relevant information in a central location. So the aspect that Kashi brought up, there's data that's internal, what beds are open, and you have to call maybe 988 to get access to that. But if there can be an outer-facing part of services that the community can directly access, as we know, younger generations first go to the internet before they talk to anybody in person or on the phone. That's just a reality of where we're going. So if we're building a system that's going to last a while, we need to build a system based on where people and human beings the future are going.
Thanks, Bipasha. And I don't know if it's possible to copy and paste what you just write in the chat like you did earlier, but I think it'd be good for people to see it visually as well. And then Puck asks, and why does the idea of an outer facing system feel scary? It's an interesting question. Dylan.
Thinking of the outer facing system of everything that might be available, I think there's been various starts and stops to that. And because there's so many different things, it becomes very, very, very tricky to try to do. And there have been several groups that have tried to do this with varying degrees of success. The other thing that I think several other folks have been talking about is fidelity of the system and what people can expect when they reach out to. And I think that's one of the hard things for us to try to grapple with is like, well, what is the standard of care? What King County might have or City of Seattle might have is going to be different from what other areas of the state might have access to. And then once we hop into Oregon or any one of our other neighboring states, the response is going to be different because the implementation is different. So that, of course, that causes more or a lack of faith in the system because we just are not always going to know what to expect. The other thing I was thinking of as folks were talking about is that we do have a lot, and it's already on here, that we have all these other lifelines and things that can be accessed. There are population-specific ones, which is awesome too. And we're asking so much of the people that are answering these calls. If we're asking so much, then I just wanted to highlight the fact that, well, how can we leverage the more specialized skills and uses of consultation for those of us on the call that have taken license exams, is that the use of consultation often is one of the best answers out there if you don't know what to do. So I'm wondering how we can just leverage those partnerships and other skill sets that we have, or when we just don't quite know what to do. And so I could reach out to like maybe the Trans Lifeline if I'm not quite sure on how I should respond to some of these other things.
So Dylan, am I hearing that you're thinking that one of the ways that we could make the system more navigable is by creating more relationships across the system and better using the talent and experience and expertise and specialties that already exist within the system by coordinating across the system?
And yeah, in some way, because if we're expecting like, or you have to do, this training, we can't expect an individual to have all the expertise in the world. But that's why in other fields, you'll consult with a specialist for those situations. And I think we also need to be able to, for ourselves as professionals, be able to normalize asking for help from others who have more knowledge and experience than us.
Well, and going back to, I think what Bipasha was saying, also knowing where to go to ask for that help, because that's a piece of information that's missing. And I'm actually reflecting, unfortunately, Sean Ford had to leave, but I'm reflecting on his comment earlier about the EMS services being hitting their capacity and his concerns about adding more trainings or expertise to the expectations of those folks. So your point there makes a lot of sense in that context too. And then Puck is commenting, maybe sometimes we're not making promises or commitments because we're afraid of, in parentheses, the liability issues of not living up to them. That is I think, a major barrier that the system faces. And so that's a really important point. Other comments from our CRIS committee members on this section? I'm looking to make sure I didn't miss any chat comments. I think I got everything from CRIS committee members. Can we just do a quick chat with Brittany? Brittany, did we get any signups for public comment?
We did not.
Okay. Well, then I think I'm going to sum up with next steps on here, which is, as I mentioned at the beginning of this conversation, then you may have seen earlier in the document, there's yellow highlighted sections. That's where I incorporated your feedback from the July meeting. I'm going to do the same thing here from this meeting. And then HMA is going to be working on incorporating the feedback from the lived experience subcommittee and the tribal subcommittee. So the intent is to deliver to you a complete synthesis document on mobile crisis response in advance of the September meeting. So we can use that as the basis of forming our recommendations for the 2024 report. Bipasha raised the question of why the work that the lived experience subcommittee to date has not been in here. And we will make sure, Bipasha, that all of that is incorporated and that you have an opportunity to review it for completeness in advance of the September meeting, as well as the input from the tribal committee. With that, let me just make sure. Okay, and I also want to remind everyone, we do have an in-person meeting in September. I think Betsy talked a little bit about that, but you should have it in your calendar with more details to come. I believe there will be some kind of remote option, but we'll keep you posted on that. And I will, if anyone gets sick or runs into a snag that day, but hopefully most of you will be able to come in person. And I am really looking forward to meeting so many of you in real life. It's funny that we've been working together for 2 years, and I've only seen the top half of your bodies. And with that, I just want to thank everyone for such a good discussion today. I really appreciated the presentation today. That was so informative. The lived experience story was really powerful. I'm going to be thinking about that well into tonight and the rest of the week. And most of all, I want to thank our community members, particularly our folks with lived experience who come to this meeting every month and provide your energy and your input and your commitment. Very grateful to all of you. Betsy, anything you want to say before we say goodbye to everyone?
No, I just wanted to come back on camera, Jamie, for the end.
Okay.
Thank you.
Yeah. All right, everyone. Well, I look forward to seeing you next month. And in the meantime, I hope at least everyone in Seattle is enjoying the rain. I got to say, I'm pretty excited about it. Have a great rest of your day, everyone. And yes, Brittany, I will save my chat.
Thank you.
Take care all.